You know, Dr. Edelman, I got to say, it's been a real honor working with you today. I'm learning so much.
I thank you, Doctor in Training, Jeremy. Flattery will get you everywhere.
Hey, well, can I run my next case by you? I think it's actually a pretty super easy peasy one.
Sure, go for it.
Okay, well, I got this 45-year-old guy over in bed too. His name is Maxwell Power.
Wait a minute. His name is Max Power?
Yeah, super cool name, right? Anyway, he comes in with about 12 hours of nausea and vomiting, but his vital signs are stable. He doesn't have a fever. I checked his CBC. His white count is pretty much normal. Flu swab negative, COVID negative. So long story short, I think he's just got like a viral gastritis. So I'm going to give him some Zofran and send him home with that and a little bit of reassurance.
Well, hold on. Tell me more. Does he have any other medical problems?
Yeah, you know, he's got type 1 diabetes, I think, since he was 15, but his A1C last was 6.9, you know, so we're all good there.
He has type 1? Well, he can be in DKA.
Really? I mean, but wouldn't his pump just make sure that he's super well controlled? I mean, they're really sophisticated now.
Well, they don't work exactly like that. And even the best patients can have DKA. What was his bicarb?
Bicarb. Oh, yeah. Okay. Actually, it is a little low. It's 16.
The plot thickens. This is sounding more and more like DKA. We should get a beta-hydroxybutyrate, stat.
A beta-hydroxybutyrate. I'll just...
Beta-hydroxybutyrate, Jeremy. It's the main ketone we use to follow patients in DKA. You know, I thought you had the stuff to be the next Dr. Steve Edelman, but it turns out I was wrong. Hand in your badge and stethoscope, son. But no buts. Hand them over and get out of my sight.
Yeah. All right.
I gotta go save Max Power's life.
I'm ruined. Hi, everybody, and welcome to our CME on CKM, Continuous Ketone Monitoring for patients with diabetes. So we wanted to open up with that fun little scene that unfortunately is all too common, that patients might misrecognize DKA. Providers certainly misrecognize DKA. This is still a huge problem. So while we started with this humorous kind of skit, it was really to set the stage for let's talk about DKA, and especially with the advent of continuous ketone monitoring, it's really going to kind of revolutionize this space. So as providers, you're really going to have to know what these devices are, who should use them, how to interpret the results, all of that, and we're going to cover that today.
Totally. And who's to say CME programs cannot be humorous?
Exactly.
Because humor leads to
information retention. So
yes.
Who am I? I'm Dr. Jeremy Pettus. I'm an associate professor at University of California, San Diego, where I see adults with diabetes type 1 and type 2. I also have type 1 diabetes myself, diagnosed at 15, and I work for the organization that Steve founded, Taking Control of Your Diabetes. He founded about 30 years ago. And who are you?
I'm Steve Edelman. Mm-hmm. Everything's the same with me, except I'm full professor now.
Okay, cool. He's always got a one-up, man.
Got type 1 diabetes when I was 15, just a couple years apart.
So if you haven't heard of Taking Control of Your Diabetes, please crawl out of the rock that you've been living underneath. We specialize here, this is our studio, in making what we call edutainment, things that are educational and entertaining to both patients and providers. So please go to our website. We have a podcast, we have a newsletter, all ways of informing both you, the providers, and patients.
And we have an excellent CME program running now on how to interpret CGM download for efficient and effective patient care.
So we're going to sprinkle humor throughout this, as always. So we started with that skit. We have a couple other skits to keep you kind of glued, because it's hard to sit there for an hour and get educated, but this really is an important topic. So what are we talking about? Well, you know, we've got these kind of listed here, but first we're going to talk about the prevalence and the impact of DKA. It's more prevalent than I bet you think. We get kind of lulled into thinking this isn't a problem anymore. It's not really a big deal. Wrong.
And
it is.
In people with type 2 as well.
Yes.
That's important.
So we want to identify the key risk factors, early warning signs, and symptoms associated with DKA, so you can educate your patients on when this is happening to catch it early. That's going to be a big theme of everything we talk about today, that early detection is going to be key. So next, we're going to evaluate the effectiveness and limitations of our current DKA detection methods. What do we do for ketone testing right now? Do we even do it? We're going to talk about that. The answer really is no. Next, explain the clinical benefits and functionality of continuous ketone monitoring. So this is the new kid on the block.
That's exciting.
As we're recording this, it hasn't been released, hasn't been approved yet. So we're getting some kind of early readouts on what these things might look like, who we might use them for, etc. And then finally, demonstrate strategies for patient education of CKM technology into clinical practice. So if you're a provider, what do you do when your patient calls you and says, my beta-hydroxybutyrate is 0.8? Is that normal? Is that abnormal? We need to educate our whole community, patients and providers, on this new kind of language and how to interpret this data.
Yeah, the patients are the end users. There's where the buck stops. And if they're not educated, they cannot really treat themselves in the field and prevent them from showing up in the emergency room in DKA. Yeah. So that's what it's all about.
Yes. All right, so here's a case, kind of like we started in the beginning. So Susie is a 47-year-old woman with type 1 diabetes. She's had it for 30 years. She's on a hybrid closed-loop AID system. She's had a long history of excellent glycemic control by whatever measure you want to look at. A1C is good, time in range is good, time below range is good, meaning she has minimal hypoglycemia, low glycemic variability. So really, a very well-controlled, excellent
She's cruising
patient.
along.
Yeah. And these are real cases. So she presents in the emergency room with nausea, vomiting, muscle aches, flu-like symptoms. Were you going to say something?
No, I was just going to say, these patients, the first time they've ever experienced DKA, which you're about to describe, is when they were first diagnosed.
Yeah.
And that's why people with type 1 forget the symptoms, and they may not have she was diagnosed 30 years ago.
Yeah, I mean, this is very close to me. I'm obviously a bit younger than this, but I was diagnosed when I was 15. That's when I went to DKA. And, I don't really remember what that was like. So some people can go 30 years and just not be used to it. So it comes out of nowhere.
Yeah.
Anyways, her glucose levels are 210. She's got an anion gap of 22. She goes right to the ICU for a diagnosis of DKA. Of note, she was recently put on an SGLT2 inhibitor because she's had some abnormal, basically microalbumin findings in her urine suggestive of early kidney disease. So we'll talk about that a little bit more. These are technically off-label in type 1 diabetes, but a lot of practitioners are starting to use these in type 1s, especially with people with underlying kidney disease or heart failure.
Yeah, a tremendous class of drugs that prevents the progression of kidney disease, type 1 and type 2, and congestive heart failure. And even insurance companies have no problems approving these in type 1s because the benefits are so great.
And, kind of skipping ahead, this is a huge class of medications that type 1s really don't have access to. And the reason for that is that they can precipitate or cause an episode of DKA. So a continuous ketone monitor may potentially kind of unlock this class of medications for people with type 1. We'll get a lot into that more. So what caused DKA here? What are some kind of risk factors or what's going on? There's a couple things kind of flagged. So Steve, what are some of these?
Well, the differential diagnosis, there's three main areas that I would focus on in this patient. She wears a pump. One of the most common causes of DKA in type 1s is the pump line coming out accidentally. And if you don't recognize it, you can go several hours without any insulin. And when your insulin levels get really low in someone that doesn't have any insulin, like a type 1, then that is the main cause of diabetic ketoacidosis.
Yeah. And we want to be clear that we are huge supporters of these pumps and hybrid closed loops. These have major benefits, improving blood sugars, reducing hypoglycemia. But the fact is, it's just rapid acting insulin that's being infused. So if there is some issue, it gets kinked, it falls out. In a couple hours, you're without insulin and you can get into trouble real fast.
Yep.
Very different than taking your once-a-day shot of Lantus or Tresiba or whatever basal insulin that's there kind of all the time. So these pumps can give excellent control, but DKA is, something you have to educate patients on. And people like Susie can get lulled into this, I'm well controlled, DKA isn't a problem for me, I don't need to know about it. We don't need to know about it until you need to know about it.
Yeah, and even if she was offered a ketone meter, which we'll talk about later, if she was, she probably wouldn't use it. She wouldn't have it with her. And that's the typical scenario.
Yeah. Another thing that's going on in her, so she presents with these flu-like symptoms. We don't really know if this is a result of her DKA, if she's, feeling kind of lousy because she's in ketosis, Or maybe she had a precipitating illness, which is another kind of common cause. So maybe she did have a flu, let's say. That can raise catecholamine levels. That can, people maybe stop taking insulin because they're not eating. These things can kind of augment DKA also. So any kind of illness is another time that patients can be kind of predisposed to DKA.
Yeah, and people don't realize that when you're sick, even if you're not eating, you might need more insulin than when you're feeling healthy. So they get under insulinized. That puts them at risk for DKA.
Yeah, you get all these stress hormones that are going on.
Sick day rules, basically.
Yeah. All right, so we got, she's on a pump. She's got maybe an illness. And then finally, we mentioned a little bit, she's on one of these SGLT2 inhibitors. Now, these drugs don't cause DKA, but what they can do is that they kind of limit how high people's blood sugars go. So let me kind of walk through this. So
you should emphasize her blood sugar was only 210.
Yeah, 210. When you think DKA, you think 500, 600, something a little bit more exorbitant. But so, if I'm sitting here, I'm not on an SGLT2 inhibitor, my pump falls out. Well, I'm going to know I'm not getting insulin because in an hour or two, I can see on my CGM that my blood sugars are high, and that gives me insight into the idea that I'm not getting insulin. Now, if I'm on one of these medications and my pump falls out, well, instead of going to 200, 300, my blood sugars might just go to 180, 190, and I lose insight into the fact that I'm not getting insulin. So it's not that these drugs cause DKA, it's just that people lose their kind of biomarker that they're not getting insulin. And a key message here is that high blood sugars don't cause DKA, it's lack of insulin.
That's right.
Yeah.
And that's called euglycemic DKA, which we will talk about in a second.
So the definition of DKA, honestly, there's different definitions based on where you go. But the way I like to think about it is the three letters, DKA. So diabetic ketoacidosis. So one, you got to have diabetes or high blood sugars. Two, you have to have evidence of ketosis. And this is where we actually measure ketones. You can do it in your urine. You can do it in the blood. We'll talk about, levels that are kind of defining of DKA, but you have to have some elevated ketones. And then you have to have the A in acidosis. And in her case, it was a high anion gap. Her bicarb was probably low, usually less than 18 is a cutoff. And then if you move forward in the ER and you actually get an ABG or VBG that shows acidosis. So you have to have those three things to actually have a definition of DKA.
Yeah, and it primarily occurs in people with type 1 because we don't have any endogenous insulin. And if the pump comes out or something else happens, like they get sick, then you can go into DKA. But it's really important to mention that it does occur in type 2 diabetes because many people with type 2 diabetes of long duration are insulinopenic, and also people with type 2 take a ton of SGLT2 inhibitors. And talking to our hospitalists, it's one of the most common reasons people with type 2 diabetes are admitted these days for DKA.
Something we weren't seeing a ton of before.
Right.
Now, euglycemic DKA, this is really, it's something that's always existed, but we really didn't talk about it much until, the advent of SGLT inhibitors. And we've already really mentioned this, but this is when you have DKA, you have those three things I mentioned, you're diabetic, you're ketotic, you're acidotic, but your blood sugar is normal-ish. Maybe it's less than 200. And again, we used to think at least over 250 for diagnosis of DKA. There's been some kind of extreme cases where people have gone into DKA with blood sugars of 120, 130 on these medications. And I already talked about the reason why. These drugs are kind of like an offset valve. You're constantly peeing out glucose, so you can keep your glucose levels down. But when you're not getting insulin, those ketones are still rising.
Yeah. When I was a fellow at the Joslin Clinic many years ago, I did a report on euglycemic DKA long before SGLT2 were even dreamed of. And you can see some of the other conditions that could lead to euglycemic DKA, typically conditions with low glucose values, like liver disease or pregnancy or too much alcohol. So there are other conditions, and like you said perfectly, it's been around for decades, but it's been brought back to light with SGLT2 inhibitors, which were discovered just serendipitously when they started to be prescribed in type 1s. And Peters and other endocrinologists said, hey, how come we're seeing so much of this? And then the awareness came about.
And we say approximately, let's say 3% of DKA admissions are euglycemic. And, you know, a reason this is important, we already talked about, again, in the beginning opening thing, that DKA can be missed in general. You add on this euglycemic element to it, guess what? It gets missed all the time because the first thing people look at when they're thinking DKA is usually the blood sugars. All right, so what is the pathophysiology of DKA? Well, the cardinal event really is that there's insulin deficiency. And as Steve mentioned, us type 1s, we don't make any insulin. So if you take our pumps off, well, guess what? Our insulin goes to essentially 0. And that's, your body thinks that it's in a point of starvation. So if you don't have diabetes, you didn't eat for, let's say, 2 days, your insulin levels would go very low. And that's a sign to your body that you need to start burning kind of your reserve energy stores, namely fat. So that's the main thing that happens. When your insulin levels drop, you start breaking down fat through a process called lipolysis that frees up free fatty acids that go to the liver. And when the liver sees all these free fatty acids in a state of insulin deficiency, it shuttles them all to ketones.
Because the brain is saying, hey, I need energy. Without insulin, glucose can't get into the cells for energy. So it says, I want some energy out of these ketone bodies. And ketone bodies lead to the acidosis. They lead to the pH being brought down. And so it's all based on excess ketone production.
Exactly. So a little bit of ketones can be a good thing, you know, for brain health, like things like that. Obviously, you get to higher levels, they're acids, and they make the blood acidic, and that's a problem. So you have this lipolysis going on. Ketones are being formed. This typically happens with high blood sugars because, again, you don't have insulin, so you're not able to dispose of glucose. But when you have high glucose levels, you get this osmotic diuresis. So, you know, like basically you pee a lot. That's one of the things that we always talk about of DKA. And it's interesting because I remember when I was first diagnosed, you know, the other thing you get is really thirsty. So I was drinking like a ton of fluids and I was peeing all the time. And I was thinking, well, gosh, I'm peeing all the time because I'm drinking so much. It's actually the other way around. You get so dehydrated from trying to get rid of all this glucose that you get really thirsty and you try to kind of like supplement with drinking. But anyways.
Well, 1970, I was drinking regular Coke.
Yeah, I was too.
And that just made things 10 times worse. You know, so the osmotic diuresis is a big thing. And then you get electrolyte imbalance, sodium, potassium, other electrolytes. And when we used to be in the emergency room, someone would come in and DK and they're down 2 or 3 liters right off the bat. So you start pouring in fluids and then following the electrolytes. But this program's not to teach you how to take care of DKA patients in the ER because we're not the right guys to do that either.
But it's helpful to remember what it is. Because time goes on and you just kind of, like I said, get kind of used to it. And you know, and we don't mention specifically, it has a mortality associated to it. People still die from DKA, especially in, you know, obviously like third world countries and things like that. But even right here in the US and our, you know, gold standard hospitals, people still pass away from DKA.
It's the main reason why the FDA has pushed back to the SGLT inhibitors because of DK, the main reason. So that's why this is so important.
So who gets it? Well, about half of people with type 1 diabetes, that's how they present, like you and I did. I always think that number's low. I would think
same here.
I would think it'd be most of people with type 1 diabetes.
AI doesn't know what they're talking about.
And then we're going to show specific numbers, but it's about 5 to 8% of type 1s per year. So that's 1 to 20 out of 1 in 10 of your patients that every year will have to go to the emergency room or, you know, the hospital or something with, you know, an episode of DKA. This isn't counting the ones that maybe were counted home.
Right.
You know, somebody identifies that they're ketotic, they take insulin, they stave off going to the ER. So it's probably much more common than we actually think. You mentioned in type 2 diabetes, it's less common, but it still happens. 1.5% of our type 2s per year. But given that there's way more type 2s than type 1s, even though it's a lower prevalence, it's still coming into the ER and things like that a lot.
I think that explains the numbers we're seeing at UCSD.
Yeah. Age and DKA, it's more prevalent in kids. children and adolescents. And there can be some racial and ethnic disparities. Primarily, it can happen in Caucasians, mostly because
most type 1s are Caucasian.
Yes, exactly. But we know that all ethnicities are kind of increasing their prevalence of type 1 diabetes. So really, there's any ethnic group that can get this. And we know type 2s has a completely different kind of, ethnic diversity than type 1. So that's not really a helpful thing, to be honest.
Well, the mortality, as you mentioned, it's important. Elderly, the people that are underserved, they're living in areas where there's no access to good health care. But that's the problem. What kills people with DKA? Their pH gets too low. It's incompatible with life. So that's the acidosis part of it.
Now, so causes and risk factors for getting DKA kind of going on. So we mentioned some of this. Missed insulin doses. This can be intentional or unintentional. On the extreme, you have these people with, kind of so-called diabulimia. They admit insulin doses because they want to lose weight or they actually want to purge and vomit and things like that. Those are those people with A1Cs of 13, 14, 15, and they're just a setup for DKA. That's on one extreme. Then you have people that maybe they're sick and they're just kind of unintentionally underdosing insulin.
Yeah.
But no matter what, you need a low amount of insulin for what you need at that time. Insulin pumps. So again, we love them, but you got to know how to triage them. If your blood sugars are going up and you're not eating and you're bolusing through your pump, you got to change the infusion site. You got to take a manual injection with a syringe or a pen so you know you're getting it. You can't just assume that your pump is working.
And we prescribe for all our pump patients insulin pens to have in case of emergency, and take them with you, especially when you can't get home very quickly.
Yeah.
Murphy's Law,
And all these pumps, honestly, they have syringes to kind of fill them up. So you can always, in kind of a pinch, use one of them to kind of inject with. But anyways, we talked about other illnesses, infections, stress. So it might be a car accident, actually, or something that maybe is not like an illness per se, but something that's raising catecholamine levels, these stress hormones that can actually kick it off too.
Serial infections.
Yeah. SGLT2 inhibitors or SGLT inhibitors in general. We have here knowledge gaps in patient and provider education. That could be a risk factor that people just, particularly on the patient side, they don't acknowledge it, or they don't recognize when they're going into DKA. That's a huge issue, and part of the reason that we're doing this. And we have all kinds of programs geared specifically to patients, because that's kind of our core belief here at TCOID is you got to take the education right to the people. Right,
yeah,
Steve?
and you as providers really have an obligation to educate your patients about the signs and symptoms of DKA so they can treat it out in the field and turn things around without going to the hospital.
Yeah.
Have you ever heard of the revolving door phenomenon?
Yeah, so these are patients that, the frequent flyers in the ER, things like that. So kind of how to identify these people? Well, a good thing that we know is that generally the higher the A1C, the more at risk people are for DKA. And that makes sense. When your A1C is high, you're generally under insulinized, and then there might be kind of closer to a cliff. If something happens, you get stressed, you get an infection, something like that.
Yeah, these are people with severe psychosocial issues and other types of stress where diabetes is not on their priority list. And they account for a pretty good percent of the incidence of DKA, the same individual 2 or 3 times a year or more.
Yeah. And this is something Steve and I actually published, 5 years ago now, but it might be kind of our number 1 cited publication ever, where we looked at all kinds of things. People with type 1 diabetes, we got a hold of medical records of 30,000 people living with type 1 diabetes in the US. And this is where we get some of our numbers, only 20% of them had an A1C less than 7. Most people are not, kind of meeting control guidelines. But we also looked at the rates of DKA, and what this figure is showing is the rates of DKA according to A1C. So first of all, there's no A1C that makes you completely safe. Yeah. But in general, with the lower A1Cs, people are at lower risk. As you go up, that kind of risk of DKA essentially goes up exponentially. And we have this 12-fold increased risk in DKA if you go from an A1C of 8 to 11.5. So I think this is something people kind of know. But if you have a patient walking in with an A1C above 9, these are people really that you need to be talking about potentially taking them off of a pump if they are on one, or just making sure that they have basal insulin going, really prioritizing at least getting your basal insulin every day to avoid DKA.
No, you said it just right. That keep cutoff point is above 9%.
Yeah. So something good to have in the back of your mind. So signs and symptoms. Well, so early recognition is important. So what are some of the early signs of DKA, Steve?
Yeah, the early signs of DKA is like having the flu. nausea, vomiting, muscle aches, thirst, increased urination, and just feeling like you got COVID. I can use COVID these days. And I think the key thing about this slide is that it's quite different than just having a high blood sugar from having a piece of chocolate cake. You didn't take enough insulin. You can see on these little cartoons, they both have blood sugars of 400. One who just ate a little more dessert feels perfectly fine, but says, damn it, my blood sugar's high. And the other one is feeling pretty bad. This is a really important slide because this is what you need to educate your patients on, is do you have flu-like symptoms, muscle aches? It's quite different than just an elevated blood sugar. And that should be the first sign that a patient may say, I wonder if I'm going into DKA.
And then as we get more on the severe side, I would say that the most important thing here that we always tell patients is if you ever vomit, you can't keep something down, you can't keep fluids down, that's your trigger to go to the emergency room. Prior to that, it's a lot of DKA can be reversed at home with proper insulin taking and hydration. We'll go over all of that. But if you get to a point that you can't keep anything down, well, then you're at real risk for kind of making dehydration worse and really making DKA in general worse. So that's always your kind of letter to the patient. Anytime you throw up, go to the ER.
Yeah, that's it.
All right, so now we're going to talk about ketones specifically, and beta-hydroxybutyrate, or BHB we say for short. Thank God we have a shortened acronym for that, is the primary ketone that we should measure in DKA.
Yeah, it's important for all you guys to remember, and gals, acetoacetate, which is measured in the urine, is not a good indicator of DKA. You could be totally misled, you could miss it, you can overdiagnose this. So beta-hydroxybutyrate is important. And then that third bullet point, I can't...
Well, and I just want to highlight that that's important because acetoacetate is what's tested with the urine strips.
Right.
And beta-hydroxybutyrate, the real kind of culprit, let's say, is something you can check in the blood.
Yeah.
And so those are important distinctions. And jumping ahead, on the CKMs are going to be measuring beta-hydroxybutyrate in real time, which is really kind of the one that you want. There's two ketones that we really worry about, BHB and acetoacetate.
I don't worry about acetoacetate.
Okay.
But this third bullet point's key. Beta-hydroxybutyrate rises before glucose in the DKA. So now if and when these continuous ketone monitors come out, they'll give us a really good warning that DKA is impending because beta-hydroxybutyrate goes up earlier than glucose.
Now, when to test? What would you tell your patients? The patients come in, they're newly diagnosed, they're checking their ketones every time they go above 180, they're kind of on top of it. And then we have the flip side that you and I probably haven't tested our ketones in a long time. So what advice do you give people and when they should tell their patients to check?
Well, I would say that first you have to educate them on flu-like symptoms. And when they feel achy, weak, like they have COVID or another flu, and their blood sugar is elevated, that's to test. But now I tell them, even if your blood sugar is not that elevated, above 200, the guidelines used to be above 250, but with SGLT2s coming out, the national organization said anything above 200 because of that reason. But to be honest, I don't think I do enough education myself.
Yeah.
I don't have a ketone meter, which we'll show in a second.
So really, anytime you have symptoms, and then anytime, just generally speaking, you have an elevated blood sugar for a prolonged period of time. We could try to put numbers on that. Maybe you're above 300 for a couple hours. That's a time you would want to check ketones for sure. So we don't have kind of strict, you must do it, but certainly if you have any, you're feeling not well, that's the time you should do it.
Yeah.
Speaking of which, Steve, I'm really sorry to do this, but I'm not feeling so great myself. Do you mind doing the next couple slides on your own? Because I'm sorry. Just give me 1 second, bud.
Jeez. Right in the middle of the program. Well, gives me a chance to go over this slide until he comes back, if he comes back. We talked about urine testing. And there is no currently approved urine testing for beta-hydroxybutyrate, just acetoacetate. And once again, it could be very misleading. But we do have finger stick beaters that measure beta-hydroxybutyrate. They've been out for years. They're actually pretty good. They measure both glucose and beta-hydroxybutyrate, but you have to prescribe them. You have to get the strips. The strips expire. You don't have trends. You don't have alerts and alarms. And I would say in the questionnaires that we put out through TCOID, Most patients don't have one, and the ones that do don't use them. So yeah, wait, hold on a second. Hold on a second. Hello?
Steve.
Jeremy.
Yeah, can you come to the bathroom real quick, man?
Come to the bathroom? Yeah. Excuse me, 1 second.
Oh, Steve, thank God you're here. I wasn't feeling good, so I came to the bathroom to check my urine ketones, but I can't make heads or tails out of this.
Jeremy, did you have to do it right now? We're in the middle of a CME presentation.
Look at this. Would you call that blue or green?
Definitely orange.
Orange. Well, that would mean my ketones are anywhere between normal and dead.
Jeremy,
that can't be right.
Put that away. Let's test your blood for ketones. It's so much better.
Oh, thanks, Steve.
All right.
So it says my beta-hydroxybutyrate is 0.3 millimoles. What does that mean?
It means you're a drama queen. That's normal. Can we get back to the presentation now?
I'm sorry. Let's go.
Hey, weren't you wearing a different shirt earlier?
Yeah, don't worry about it, Steve. Let's go. Man, Steve, I'm sorry. I was really embarrassed about that. Gosh.
God, you should be. We're in the middle of this program.
Anyways, so it turns out we actually have several ways to measure ketones. We have urine testing, as I demonstrated, didn't work so great. And we also have blood testing, which can actually measure your beta-hydroxybutyrate. So the one meter that I'm most familiar with is this like Precision Extra shown here. And I like it because it is literally a blood sugar meter. So you enter one strip and it gives you a blood sugar reading. You enter a specific ketone strip and it measures your ketones. So it's a process that every patient with diabetes is very familiar with. It is checking your blood sugar, but just with a different strip. So I personally, these sometimes can get covered by insurance. The meters themselves are very inexpensive. You can get them on Amazon for literally $15 to $20. The strips can be definitely a little more expensive. However, you may only need 10 of them. And that can get you through like a long time because people shouldn't be checking these like, every day. But every patient really, and I think we do a bad job of this, should have one or have access to one and be able to check their blood or their ketones and know what the results mean.
What percent of your patients with type 1s have a ketone meter like this at home?
I would
be
say
honest.
Only the ones that I have on SGLT inhibitors. Those are the ones that I really kind of press on. This is a really important part of your treatment now. But just kind of your run-of-the-mill people with diabetes, it doesn't come up. And I think that's part of this whole issue, right? Is that we just don't talk about it. And there's a lack of providers wanting to do this because honestly, if you're watching this, think right now what a normal beta-hydroxybutyrate level is and what high is. And don't feel bad if you have no idea. And the point there is because you don't want to give something to a patient where you don't know how to interpret it. So there's that falls into the discussion. Anything else to say about that?
No, you're right.
But I wish I had one of those in the bathroom. Maybe you, next time just bring one for me and that'd make it a lot easier.
Oh, sure.
But yeah, you have to carry an extra device. You have to, know how to use it, all those things. So with that, we're transitioning to CKM and leaving behind the fact that we don't use these devices. Even if we have urine strips or blood meters, we don't use them. We don't know how to interpret them. So now with CKM, this is going to be a major development where you can in real time see what your ketones are.
Yeah, carrying an extra device is what people with type 1 diabetes do not want or need. And even if you measure it, and even if you understand what that number means, it's one point in time. It's kind of like a glucose test at one point in time versus CGM, where you can get frequently sampled values, trend arrows, alerts, and alarms. And this is what CKM could offer.
Yeah. And thankfully, we don't need to explain this much to people like when we did when CGM first came out.
Totally.
What it is and what the benefits are and how it might be done. And people don't want to wear this device. It's too much information. We've crossed that bridge with CGM. Now, the idea here is that you would wear a CGM, essentially identical to one that you're wearing already, but it would also measure ketones. So there's no additional burden to the patient. It's extra information.
Same sensor.
But that's a really cool concept, right? Of essentially getting more bang for your buck if you're going to wear this CGM. And we'll talk about who could benefit from the ketone side the most, but why not kind of add the ketone measurement also?
Yeah, and just having this device available, the CKM, is going to increase the conversation about DKA. And just that alone is going to help people recognize it when it occurs.
Yeah. And it's something, different than glucose because we want to know what our glucose is all the time. every little break we take, we look at our blood sugars, your beeper always goes off, those kinds of things.
Excuse me, yeah. Oh, 128 straight across.
But with ketones, you really don't want to know unless it's a problem, right? So I kind of think of it as more like an airbag on a car. Like you want it there, when there's an emergency, but otherwise you don't want to see it. You don't want to kind of know what it is.
Yeah.
So, if you kind of have these ketones being measured in the background and only alert you when there's a problem, well, then you got kind of a winning device, I suppose.
Totally. I think the folks who are developing this CKM have put a lot of thought into it and got advice from a lot of diabetologists like you and myself.
Mm-hmm. All right, so benefits, we talked about prevent DKA, home treatment, stave off DKA completely, eliminate ER, stays.
Just one word on the benefits part. I mean, the purpose of CKM, in my mind, is to let the user with type 1 and type 2 and other people at risk be the first to know about it out in the field. Mm-hmm. And then right away they say, okay, I don't have to think about, am I going into DKA? I am. And what are the things I need to do to mitigate at home so I can take care of it and not even have to show up to the hospital? It's going to save so much, not only morbidity, mortality, use of the healthcare dollar, but quality of life.
Yeah. And we don't have a specific bullet point there, but I mentioned before, is a potential increased safe use of SGLT inhibitors in type 1 diabetes.
That goes without saying.
That this is a class of drugs that essentially type 1s aren't using, and we're missing out on all the benefits. I'm tired of it.
And and maybe the FDA will be a little more lenient in improving these devices. It's just a matter of time that the FDA is going to approve these for type 1. We might as well use them safely.
All right, so, it says... we said just kind of think about if you know what a normal beta-hydroxybutyrate is.
Yeah.
And, kind of deer in the headlights look because most people don't know.
Yeah. And don't feel bad about it.
You gave a talk at, that was in
EASD in Amsterdam.
In Amsterdam, and you asked people this question. People raised their hands. They were full of it.
Well, yeah, I mean, I didn't give them a chance to. I just showed this picture.
Yeah. All right, so here's some levels and when to be concerned. So here's some things to kind of make yourself kind of familiar with. So I don't know any better way than just to say you're going to have to start kind of committing these to memory.
Yeah.
Just like we did with blood sugars. 80 to 120 is normal and, over 200, whatever.
Put them on your cell phone or something.
So first of all, it's in millimoles per liter. Normal is anything less than 0.6. So if you're lower than that, great. You get into mild ketosis, 0.6 to 1.5. And that's an area that, especially if you get over 1, you might be wanting to be a little bit more vigilant. This is when some of your kind of actions would take place let me check my pump, let me maybe get hydrated, am I feeling well, those kinds of things. Then you go up to moderate ketosis, 1.5 to 3. This is definitely where you want to intervene. Do the things that we're going to talk about again, making sure you're taking your insulin, things like that. Anything above 3 is, very consistent with DKA. And obviously, the higher you get, the more, concerning things are. By the way, we've done interesting studies with patients in type 1 diabetes at our research unit, where for various reasons we want to see their ketone levels. And we've actually done studies where we bring them in, we take their insulin pumps off, and so they're not getting insulin. And then we measure their beta-hydroxybutyrate over a period of 8 hours. And after about 2-3 hours is when you start getting in trouble. So it doesn't take a very long time to get into kind of these ketotic ranges. And by the time somebody was, after about 8 hours of no insulin, they would be in this over 3.0 kind of level. So if you're wondering about time course of how rapidly this sets in, that's an estimate. Now, if you're sick or something like that, that just expedites things. That kind of speeds the curve up.
So you actually did this on purpose.
Yeah.
So for you healthcare providers with type 1, don't volunteer for his studies. What's in red is just to remind you that blood sugar does not have to be that high. And the thing is, these are levels that we know now. We haven't had continuous ketone monitors ever. Mm-hmm. So there's going to be a gray zone on either side, and we're going to learn so much about the ambient beta-hydroxybutyrate levels in people in the free living state. Mm-hmm. What happens with exercise? What happens with alcohol? What happens with illness? And in one individual, you might get to, let's say, 1.8 and be going into DKA pretty rapidly. And others, you might be 1.9 or 2 and feel perfectly fine. So we're going to learn a lot. That's the bottom line.
And, you know, what we haven't talked about at all is there's a lot of people in kind of the health world, let's say, they're interested in this also that don't have diabetes, that people actually target, you know, levels of ketosis when they're doing fasting or whatever it is. That's very different because, you know, if they don't have diabetes, they're making insulin, they're kept safe to a certain degree.
Yeah. But
that also will be probably a use of this technology for sure.
Starvation ketones are different than from ketoacidosis.
Yeah. Years ago, before I even met you, I made a video, I made it at home on my iPhone, about what life was like before and after continuous glucose monitoring, CGM. You know, so I went low at night, I woke up, my blood sugar was 50, I stuffed my face, my blood sugars went high, I took insulin, I came back down, versus after CGM, waking up with an alarm, hey, you're 80, just drinking a little juice, going back to bed.
I'm laughing. It was pretty funny. It was the low blood sugar blues.
Low blood sugar blues.
Yeah.
You know, it's
a classic.
Sweeping the nation.
It's on Netflix now.
You can put it on YouTube. I've got upwards of 6 likes, I think. So, but we wanted to use that as kind of to make this video about how CKM might change what goes on in terms of DKA, of what life is like now without these continuous ketone monitors, and what it might be like for a patient once they get on these systems. So let's roll that.
Take a look. That was pretty amazing, Jeremy. And I think that was a very good reenactment of what life is going to be now that we're going to have CKM in the very near future. So it's awesome.
Yeah. And I mean, like, it was kind of a dramatic video, but actually not that dramatic. Like, you know, most cases of DKA, people go to the hospital, it's completely unrecognized. If you had a device that tells you when you're going to, like, you know, ketones, like a lot of this trauma can be avoided. So, all right, what do we do when somebody has mildly elevated ketones? They're looking at their CKM that they just got out of the box, they slapped it on, you know, now they're seeing levels of 1, 1.5. When you tell them that they need to do some kind of medical intervention, what might that look like? Well, when we first noticed that DKA was becoming a problem in people with SGLT2 inhibitors, we developed what we call the STITCH protocol. Yeah. And you want to go through it?
Well, I was just going to say that the STITCH protocol, as you mentioned, is the number one thing is stopping the SGLT2 inhibitor. Like, duh, of course. But 2, 3, and 4 have always been around. Yeah. And there's like 100 different protocols, and they all include 2, 3, and 4. I'll do 2, and you do 3, and then we'll figure out 4. Well, insulin. Insulin, insulin, and more insulin. And when you're in ketoacidosis, your body or your patient's bodies are resistant to insulin. So people need usually 2-3 times as much. And hopefully you have a continuous glucose monitor to see the glucose levels. But people are resistant, and I think the people's biggest mistake is they don't give enough insulin.
Yeah, totally. And so when your ketones get above, let's say 1.5, you have to assume your pump's not working. You change your infusion set, you take your injection through a syringe. And what I see all the time is the pumps, especially the AIDs, are trying to correct the blood sugar. So if the patient puts in like, what recommended bolus would you give? It's like 0.8 units or sometimes nothing at all. And honestly, a lot of the times you need 10, 15 units, like large amounts. So, you can do the kind of that 0.1 units per kilogram as a rough estimate. So somebody's 70 kilograms, 7 units, but you need like a big slug of insulin.
Well, we use the rage bolus suggestion.
That's essentially what that is. And then you can do that every hour or 2 hours until you see at least your blood sugars start coming down, or your ketones, if you're wearing a CKM or testing them, you kind of start to turn the tide. So kind of appropriately aggressive insulin administration early is the key to all of this.
Yeah. Well, let me do 3. You do 4. Because I'm always big on that.
Keep stealing my things.
Well, you know what?
I did 1 too, actually. So you can do 3.
Okay, 3 is extremely important because most people think it's counterintuitive to take carbohydrates that might raise your blood sugar. But this is 30 to 60 grams of carbohydrates with a ton of insulin. And that, with the insulin and these carbohydrates, the brain is now being told, hey, let's cut off the drive to produce ketones because we can utilize these carbohydrates now. And I've heard many doctors say, even pediatric endocrinologists say, it's the thing that can turn off DKA in so fast. And so people forget about that. And then, so that's it. You have to remember carbohydrates.
Yeah, and it's especially important for people that are on SGLT2 inhibitors where they might have a normal blood sugar. So they might need to take these carbohydrates in order to allow them to take these kind of larger amounts of insulin also from a blood sugar standpoint.
That's right.
So a couple reasons. And then the last one is hydrate. And you really can't kind of overdo it here, although it needs to be with something 0 calorie. I really like a Gatorade Zero or a Powerade Zero because it has electrolytes in it and it's fluid and it generally tastes good. So drinking, let's say, the equivalent of kind of like 12 ounces of these every 30 minutes, an hour, or something like that to really kind of hydrate. Because like you said, if you go into the ER, we're going to give you 2-3 liters of normal saline through your IV.
Yeah, and I purposely didn't put Gatorade Zero because I know what you mean. You don't want to add sugar. But if you're going to use the carbohydrates in a Gatorade, it's kind of double. You're getting 2 things with 1 drink. So.
Yeah. All right, so what could a CKM look like? So we mentioned at the top that
could.
Yeah, we don't have these yet.
We don't know what they look like. In fact, we're gonna put a patent on this.
Yeah, but generally, like we said, there's several companies working on this that will use their existing platform of the sensor. So it probably won't look different from a sensor standpoint.
Right.
But the readout, what comes to the patients and the downloads that come to the providers will look different. So in general, the kind of idea here is if your ketones are normal, less than 0.6, leave me alone. I don't need to know unless it's a problem.
Unless your trend arrow's going up.
Your trend arrow maybe, or then you can set, again, with these different systems, potential alerts.
Yep.
Notify me at 1.0 or 1.5. And then all of these will have like a mandatory kind of thing. Like with our CGMs, you can't turn off the low blood sugar alert for less than 55.
Right.
Same kind of thing here. It'll be, for example, anytime I'm above 3, start screaming at me with some optional alerts.
Or before even.
Yeah. So some optional alerts on kind of like the milder ketone levels, but a must-have for the kind of extreme situation.
Yeah, this will be important for you providers to educate your patients on, because you don't want them calling you every 5 seconds. Oh, my ketones are going up. So this education is key, and apparently it's going to be a color code, just like green, yellow, and red, to go look at the different levels.
And once we all start getting these in our hands, literally, I think these numbers will become more intuitive.
Oh, totally.
And, like we start to kind of know what they mean. Just like I said, like with blood sugars, it's just the back of our hand now. We know or A1C or whatever other number, LDL. We start learning what range we want.
I mean, I'll tell my patients, you hit 1.5 and the trend arrow is going up, you start thinking, am I feeling good? Is my pump line in? Am I on an SGLT2 inhibitor? What's my blood sugar? How am I feeling?
Yeah.
And then you follow it. One of the things we had on the previous slide is you got to just follow closely. And then you can decide on treating yourself at home, or you get to the point where you're vomiting, you've got to go to the ER. But the goal of the CKM is to get to patients before they vomit.
Yeah. So other features we mentioned, remote monitoring, they kind of auto inserter, all these things that we're accustomed to with CGM. So I don't really think this is worth belaboring, to be honest. Like, the different features, other than what will be different is what the user and the provider might see.
Yeah, and you might have someone that's following.
Yeah. And what we don't know, but I anticipate will happen, is that you get your CGM download, which we've now are all familiar with, your average blood sugar, your time in range, these kinds of things. I anticipate there'll be a readout of your average, ketone level, maybe a time in range for ketones, those kind of thing. So you can get an idea when you see a patient, is this somebody, we need a new level of what's appropriate for time in, a good ketotic range. And if they're above, 2% of the time, let's say, then start talking to them about, are they missing insulin doses or whatever it might be.
Yeah. And this device is going to be invaluable for the pediatric and adolescent folks with type 1. Absolutely. Because they have a much higher rate, and this is where the parents really want to be involved and treat them early.
Yeah. And then once approved, we're going to learn a ton. We generally in research, we'll do like a fasting beta-hydroxybutyrate. And if you're lucky, maybe again during the day. But now you're going to have, every couple minutes, these levels. We're going to see how it fluctuates with meals, with exercise, overnight, all these kinds of things. We're going to get a ton of data and lots of cool kind of like research, I think, that'll come from this.
Yeah, and for type 1s that might do intermittent fasting, or type 2s for that matter. So this is really the tip of the iceberg in terms of our information knowledge about beta-hydroxybutyrate in the free living state.
Yeah. So impact on clinical flow, I think it'll be a lot of just like I said, let's get these downloads, let's look at them, let's start establishing what kind of is normal criteria for these ketone levels, when you might want to kind of key in on a problematic area for a patient, very similar to what we've learned over time with CGM, and they'll be right there on the same report. So it's not like you're going to have to plug in another thing, another code, or another download or something like that. It's, how we've always wanted CGM and pump information to overlay. This is the same kind of concept.
I think the bottom line is it's not going to impact clinical flow because the way the device is made. So that's important. You don't have to change your office staff, go through a ton of education, download the data. Mm-hmm. And then the other thing is dealing with calls.
On-call stuff.
Yeah.
And honestly, we should all already have kind of ketone plans that whoever's on call knows. We might be getting these more now, but we'll have levels. Yes, certainly if you're above 3, you got to follow the stitch protocol. If you're above 1.5 and you're still going up, you have symptoms, follow the stitch protocol. But it's just, again, to highlight those things, insulin, carbs, fluids, and a lot of those. Yeah,
absolutely. And we're going to be producing a video for patients on our tcoyd.org website, and you're welcome to send that to them as well. We're going to have them educated on what to do as their beta-hydroxybutyrate levels start to go up and go above critical levels.
Uh-huh. So future directions. So I like this, lessons from CGM adoption to hopefully accelerate CKM. So CKM came out first. I think it'd be a tough sell, that we're going to put these devices on people and, DKA doesn't happen that frequently, but we already have this great platform where CGM is the standard of care for everybody on insulin, and it's becoming more and more just the standard of care, period. And now who would we add the ketone part to? We can talk about who would be kind of our top priority next. We're going to have to talk about cost. I don't really know what that's going to look like. Insurance coverage, all of that.
$50, I'll give you one.
Yeah. We assume this is going to cost more, right? If there's then the CGM alone. We don't know about insurance coverage. But I guess it's going to be like CGM. When it first came out, it was very difficult to get. And as the data improved, now, like I said, it's standard of care. Everybody covers type 1 diabetes and CGM, and most people, type 2s also. This might be a kind of a similar rollout with CKM as we realize some of the benefits.
Yeah, and I think if I worked for an insurance company, I would just look what we pay out to put someone in the ICU for 3-4 days, emergency visit. You'd pay for 1,000 CKM devices. Yeah. So I think you save not only money, but morbidity, mortality as well. And I like the idea of someday putting this, connecting the data of beta-hydroxybutyrate with a AID system. Obviously these things are going to have to get smart, interpret what that means, maybe double the reduce the sensitivity factor so people get more insulin based on if they have ketones or not. As an example, increase the basal rate.
And then I like the idea of the potential for inpatient use. Let's say you do get admitted for DKA. We've treated many patients with DKA, and it would be invaluable to know their ketone levels in real time, because when you measure a blood sample of somebody's beta-hydroxybutyrate, I'm not kidding, you get it back in 2 days. It takes a long time. Maybe 24 hours if you're lucky. So having this like in real time of seeing how somebody's responding to their treatment for DKA, I think could be huge.
And how many times have you heard of a patient being discharged for DKA way too soon?
Yeah.
The glucose may be good for the last 4 finger sticks, because we can't use CGM in the hospital now either. And then they say, oh, you're fine. But they probably, if they still have a lot of beta-hydroxybutyrate around, they're not safe to go home.
Yeah. In terms of timelines, we're filming this, kind of mid 2025. They've always said sometime 2025 that we hopefully have our first on the market, but we don't really know.
It's September.
Yeah. All right. So it's kind of late.
3/4.
Yeah. I was trying to keep that vague, Like
well, we've heard that it's going to be at the end of this year or the beginning of next year. Okay. So we're close.
All right, so who's at risk? Who would you start with? So basically people with type 1 diabetes. And I think you're right, like kids, adolescents, that would be my first priority. I think that would give some peace of mind, I think, to parents too.
Yep.
And then like I said, these get cheaper and more, like easier to use, things like that. Honestly, if the cost was exactly the same, why not just put them on everybody?
And every CGM.
Yeah. Exactly. But you might start with a subset of type 2s. Those are maybe have had DKA or they are long-standing on insulin, those kinds of
on SGLT2s.
Exactly. So anybody on SGLT inhibitors would be a good place. Pregnancy. Another key area.
So important.
So, you got to be really tight with your glycemic control during pregnancy. You always want to be, on the lookout for ketosis. DKA can be a traumatic event for mom and baby. So avoiding that, I would stick this on every person with diabetes during pregnancy.
Yeah, and there are high-risk OB folks that will not prescribe a pump to a woman that's already pregnant. If she has planned pregnancy, put her on a pump, get her used to the system. But because one episode of DKA can be demise for the fetus. So this will really be awesome for the pregnancy.
People with eating disorders, this is a tough one because these are just difficult patients in general. If they're, intentionally underdosing insulin, they're going to have high ketones. So absolutely this patient group could benefit from this, but you're really going to have to educate them. If you're going to wear it, you got to do something about it. And that generally means taking insulin and things like that. So very helpful, but another kind of piece to maybe help with that very difficult patient there.
Yeah.
We have people that are maybe isolated. They don't have quick access to the ER, things like that. People like Steve, who are just constantly drunk, drinking alcohol all the time.
Yeah, you took my line away.
I know, because you always say like something to me, so I got to cut you off there. Maybe, and then people with recurrent DKA. I mean, the list goes on.
Yeah. Let's go, recurrent DKA, the revolving door. Sorry to interrupt.
Yeah, no, that was
But you mentioned already, it's going to be a challenge for some of these people with psychosocial issues to wear a CGM, let alone a CKM. So, that the onus is on all of us to get healthcare professionals who specialize in that kind of area.
So key takeaways, we've covered a lot. Honestly, talking through this is getting me excited about it. Because, how often do we get like a kind of a brand new technology in diabetes? And that's what we're really on the precipice of.
Yeah.
So the points here, key takeaways, DKA, it exists. It still happens. It's under-recognized. It's underappreciated. People don't know how to catch it, how to diagnose it. And treatment sometimes can actually be lacking too. So it's a big problem. Our current ways of measuring ketones, whether you do it in the urinal like I did or just on a blood meter, are problematic at best and generally just not done. So they essentially are non-existent. So as a remedy to this, we now have CKM coming, which is going to take us from 0 to 1,000,000 miles an hour in terms of data that we have around ketones. And then finally, this one on this last point, this is yours.
Yeah, education is key. That's where it is all at. I mean, primarily to the person living with diabetes out in the free living state to recognize it early and to do risk mitigation. And secondly, but secondly, is the healthcare professionals. And it's all of our role to educate our patients.
Yeah. So we're going to end with some kind of additional resources for you guys. Our own TCOID website, the ADCES website who accredited this program. We also made just some links here to some of the videos that might help, where we made a patient education video on DKA. Everything that we just said in terms of identifying DKA, just a little, more in lay terms and direct to the patient.
Yeah.
So maybe that's something that you save and you literally just send to them, or you put in your little after visit summary or whatever. And then we also did a podcast on DKA. So you can link on that too. These are great resources, completely free to share with anybody. And if this is your education to patients, this saves you time. Great.
Yeah.
Please get this out there to your patients.
Yeah, absolutely. We appreciate your time, and we're both excited about CKM. I hope you will be too.
Yeah. So make sure to follow us on all these social platforms, like our podcast. This is unfortunately the currency these days in terms of giving us feedback. So we appreciate you listening, appreciate you supporting taking control of your diabetes, and hopefully we'll see you on the next video.
Yeah.